days, then it will become necrosis, and then post development is starting, and then size is increased. This is a pathophysiology of the mesenteric circulations. How the abscess develop in the livers. Liver doesn't got the direct infection from the intra-abdomens. It has some coverings, immune systems. Means in other patients, when the patient is suffering from intra-abdominal infections or peritonitis, why at that times there is no liver abscess? Most of the patients are fecal peritonitis, pyogenic peritonitis, ruptured mesentery or abscess, pelvic abscess, appendix ruptures. But at that time there is no liver abscess. Why? Because it has some protective anatomical structures. To develop the liver abscess, it is necessary to enter the organism inside the liver, in the hepatocytes, hexagonal cells, hepatocyte cells. And when it enters only through the mesenteric circulation, the portal circulations. Mesenteric become attached to the portal circulation. This is the things. Then now there is a differential diagnosis of the amoebic and pyogenic abscess. Whether it is amoebic liver abscess or whether it is pyogenic abscess. Simply, this is also pus collections, this is also pus collections. But you can judge it from after the pus culture for routine and microscopic examinations. When you are going to aspirate the pus, it's sent to the routine and microscopic examination. It is a post-procedural diagnosis. Before the procedure, if you had done the stool examinations for ORs, some organisms, if it is present with some ORs, some organisms, oocytes is there, then it is a pyogenic abscess, amoebic abscess. Most of the time pyogenic abscess have not such conditions. Fever is in both sides, pain is in both sides. Then what is the management? First surgical and medicals. We go first the medical management. What is the medical management? To admit the patients. For what purpose? To give the rest for the liver. How you can give the rest for livers? When you should keep a very light diets, minimum diets, and give the IV fluids from outsides. Then liver does not act. It has no excess metabolism rate. When patient is in the minimum foods, then the metabolism rate is also decreased. Liver don't become overloaded for the digestions. Then second, proper IV fluids. Most of the times DNS dextrose is necessary to increase the liver metabolism. To increase the metabolism. Then third is IV antibiotics. You are covering the gram-positive negative antibiotics, streptococcals. But along that antibiotics, imidazoles is a very important antibiotics. Then what are the imidazoles? First, metronidazoles, tinidazoles, ornidazoles, cyclinidazoles, sapronidazoles. These are the antibiotics. This is oral with IV. This is only oral. This is a oral. This is the oral. This is the oral routes. Nanta rifaximin, GIT specific antibiotics. Nitrosoxazonides, nitrazoles. These are also other next three more. That has become 7. The most important role is now when the patient is in your premises. You have to prepare the IV. What is the dose of the IV? Is 2 gram TDS, I think. TDS dose per day. Stat dose 0.4 gram, and then 2 grams. You have to search this from this. It lyses the pus. loculations, accuracy of the pulse will be developed. This is the main important thing. This 3 days treatments, wait and watch. Then again do the sonography. Okay. If the patient is symptomatically covered, then give this any one antibiotics for 7 to 10 days constantly after the discharge. Then it will cover the abscess. This is the medical management. Now where it depends. Patients. आता analgesic त्याचे जे आहे तर analgesic most people non-hepatotoxic analgesic. Paracetamol is a hepatotoxic. If you are giving 1 gram morning, 1 gram evenings, it will become 2 grams. More than 2 to 3 grams, it will become hepatotoxic. So only prepare the tramadols or Dynapers. Bas. Don't give the paracetamol. Nimesulaides. Nimesulaides is now banned. Most of the people are not going to use. I had never used these things. But it is also more hepatotoxic. Then as per needs, multivitamins for to boost the liver metabolism. B complex will boost the liver metabolism always. So it is necessary. Then depend PPI other support depends on the patient's symptoms. Then hepatotoxicity, liver stimulus, there is too much masala. What patients require. I am saying only a definite and specific. This is the must. Then another is a support. Then what is it, and when surgical management is started? First, size, volume of the abscess cavity. If the size of abscess cavity is more than 5 to 7 centimeter, then medical management will fail. If the volume is more than 60-70 cc, then there is a surgical management is must. Otherwise, if you are going to give the antibiotics suppressing it. When antibiotic is started, there is no increase in the WBC neutrophils. You are seeing everything is comes out the normals. It is due to antibiotic effects. But don't see the WBC and neutrophil leukocytosis index for the patient is normalized. You have to see the size and volume of the cyst. If the size and volume of the cyst is not increased, then go for surgical management. Then surgical management, what? The first is under USG guidance, pigtail catheter insertion. It is a surgical interventional procedures. Then second is cystostomy. Cyst should be break and to remove the
cyst.
It will be open. And the third one is a laparoscopic cystostomy. Put the laparoscope inside. At that time, when laparoscope is towards the visions, you have to put the drain from outside to inside. आपण जसं लॅप पोले केलं जसं ड्रेन टाक तसा आणि तो ड्रेन you have to manipulate guide with your instruments and go inside the abscess cavity. Before that, you have to judge on the visions with the help of instrument judgments, or you can to insert the needle for the aspirations. If you are confirming, it is a sex changing test. Put the needle from another ports. If you have no facility in our premises, but you have the scope, laparoscope, then you have the more scope. You have the scope, then you have the more scope. Then not necessary to radiologist. Simply put the camera port, then put the second instrumental port one only, with the help of instrument ports, operating port first and seconds, instrumental ports, two ports. With the help of one port, you can manipulate the levers, and another port you can judge where the surface of the lever is a bulge. You can introduce the needle inside your port. You can aspirate. If the pus is in your syringe outside the abdomen, you are sure that this is the only pus cavity. At that time, you can insert the drain from outside to inside of the abdomen. You have to manipulate with the help of grasper and put inside the liver. This is laparoscopic cystostomy. This is open cystostomy. This is more harmful. For simple cyst, you can, this is old methods. But nowadays you can do the laparoscopic cystostomy, or other is pectoral catheters. How the pectoral catheter works? If you can see the PCNLs. We had kept the pectoral catheter in the OTs one. This has a multi-purpose. Okay. The knob for the attachment of the bags. This catheter has one needle. This needle comes out from the tip. And over the tips there is a multiple purposes on the tips. This needle guide to you for the under the USG probe. You can see you are inserting the needle inside the cavities. This is the indicator. Guide is indicator and is to strengthening the this curvature. To strengthening the curvature and to guide for the probe. Yes. You can see this. This is a radio opaque, radiolucent. This is a radio opaque. Metal is a radio opaque. You will judge to yourself you are exact inside the cavity. When you entered inside the cavity, you remove the needles. And why this shape? Because cavity is always rounded. From all sides, pus can be entered inside and it will be then outside the body. That's why there's a kinking, coilings, like a nephrostomy tip. Like a nephrostomy tip. This is the pectoral catheterization. So, today we can go for the pectoral catheterization of the cureations for your concept clearance. There is no harmfulness. At least it will be drained out.